patient to Arvind or to Dr. Toprani, we can reduce the intensity of surgery, breast conservation surgery, larynx preservation surgery, maintaining the anal sphincter, colorectal surgeries, and there is a window of opportunity to study the role of immunotherapy, the role of chemotherapy, the role of combinations in a short frame of mind. 4 cycles, 6 cycles of neoadjuvant treatment, then surgery. You have tissue up front at diagnosis, you have tissue after completing your neoadjuvant treatment. That is a unique opportunity to study the effectivity of the treatment very quickly. Don't have to wait for disease to progress, don't have to wait for overall survival. And then I already mentioned this organ sparing treatment or less intense surgery. So we know that when you have a patient with a tumor, the neoadjuvant immunotherapy triggers a broad and diverse T cell response in the presence of the whole tumor. So when you have the whole tumor, you have lots of these immune cells in and around the tumor. You have tumor infiltrating lymphocytes, and if at that time you use, in the neoadjuvant setting, you use your immuno-oncology agents or immunotherapy, then you stimulate all these intact cells. If you do this in the adjuvant setting, when a surgery has been done, the tumor has been removed, then you don't have all these, you have a relatively immunodeficient situation. So that is one of the advantages, one of the rationales why neoadjuvant immunotherapy is being used. How does neoadjuvant immunotherapy help in micrometastasis? So this is the situation at baseline when the patient comes to you. These are the tumor cells, and these T cells in the pink, these are the inactivated or sleeping T cells. So they are just sleeping over there because the tumor has produced a shield. The shield is the expression of the PD-L1 ligand, and the immune cells here don't recognize the tumor as foreign. Now if you break this shield, if you give the PD-1 or the PD-L1 agents, then you activate these T cells and you increase the number of these T cells inside the tumor. So the tumor infiltrating lymphocytes are significantly increased. And these green cells, these are the activated T lymphocytes. So you give these sleeping T cells a kick in the butt and awaken them. And then these cells not only start to work against the tumor in the neoadjuvant setting, but they persist in the blood post-local treatment, post-surgery, and they circulate. T cells are obviously circulating all over the body, and then they take care of the micrometastasis. Wherever the tumor cells are, they will recognize them and they will knock them out. So that is the premise of why immunotherapy works in the neoadjuvant setting. We have data for several studies. Lung cancer, Dr. Arvind will focus on. I'll give you just a snapshot. This is data, small data, like a trial subset of patients with myeloma, patients who received, small number of patients, 10 patients in each arm, just a proof of concept study. In the neoadjuvant setting, if the checkpoint inhibitors were given, the overall survival 90%, in the adjuvant 70%, surgery only, no immunotherapy, survival 50%. And then this was the trial which was done, 86 patients. You can see not as much as this, but some difference in the overall survival. And our shining example, which is quoted at every medical oncology meeting these days, the Keynote 522 study. For those of who are not aware of this, I think every medical oncologist is aware of this. This is neoadjuvant pembro or placebo plus chemo, followed by adjuvant pembro or placebo for high risk early stage triple negative breast cancer. For many years, some of us felt that checkpoint inhibitors or immunotherapy has made inroads in most solid tumors, but it has not done so in breast cancer. So now we have a subset of patients of breast cancer, the triple negative subset, in which there has been a major role of checkpoint inhibitors. So this was the Keynote 522 study presented in this year's ESMO at Barcelona, and also a New England Journal publication at the same time. Patients more than 18 years of age, newly diagnosed TNBC, chemo-naive, had to be T1, N1, N2, or T2 to T4, N0 or N2. Good performance status, had to have tissues for PDL1 assessment, stratified by node status, tumor size, and carboplatin schedule, whether given weekly or given 3 weekly. So this was the neoadjuvant phase, which in the test arm consisted of pembrolizumab given every 3 weekly, and the chemotherapy 4 cycles of paclitaxel followed by 4 cycles of anthracycline cyclophosphamide. Pembro continued 3 weekly. Then the local treatment surgery, either BCS or MRM, as per the discussion and the decision of the surgeon. And in the adjuvant setting, for 9 more cycles or for 27 weeks, the checkpoint inhibitor was continued. In the control arm, same chemotherapy, 4 cycles of paclitaxel followed by 4 cycles of anthracycline cyclophosphamide with placebo, and placebo continued for 27 weeks in the adjuvant setting post-surgery. And this is the overall survival curves for you. With a 5-year overall survival rate, 86.6 versus 81.7%, a hazard ratio of 0.66, and a very statistically significant p-value. So events in the pembro plus chemo group, about 15%, and in the placebo plus chemo group, 22%. So way more events in the control group as compared to the investigational group, which received chemoimmunotherapy. And this is the forest plot, the subgroup analysis. Then you can see that other than very large tumors and other than age more than 65, the combination of pembro plus chemo in the neoadjuvant, followed by the same in the adjuvant, or followed by only immunotherapy in the adjuvant setting, was beneficial across subgroups. So benefit number 4, improved surgical outcomes. So I think this is what Arvind is going to focus on. This is an extremely nice way of the river plots, these are known as. So this is in the pembro arm, this is non-small cell lung cancer. Again, I think Dr. Arvind will elaborate on this study. This is the Keynote 671 study. 300 patients in both arms, pembro plus chemo in the investigational arm, and only chemo in the placebo arm. So downstaging by as much as 40% if you use a combination of chemoimmunotherapy. So from N2, a significant number of patients, this is at baseline, and this is post-surgery. A significant number of patients became N0, and much less N0 as compared to only chemotherapy. So you significantly downstage the disease. Then this is the Keynote 522 again, the triple negative breast cancer study. And you can see that the nodal status, this is the group which received the chemoimmunotherapy plus only chemotherapy. There is a significant difference between the two. Rationale number 4, this gives you a window of opportunity to study the intervention, whether chemotherapy or chemoimmunotherapy in the you get an in vivo assessment of the chemosensitivity, and this is a study on colon cancer, 2 double checkpoint inhibitors, and you can see the benefit in the post-operative specimen. Organ sparing, again, I think this is important from our surgeons in the audience. We have this across the board for so many tumors now, colorectal cancers. So multivisceral resections reduced by 30%, pathological remission rates increased by 70%, better 3-year disease-free survival, and decreased the use of open surgery significantly. You could get away with a small tumor being removed laparoscopically. And all of us know this dostarlimab study in which colorectal cancers who had mismatch repair deficient tumors, 15 in number, given just single agent PD-L1 blockage, dostarlimab, and after a 2-year follow-up period, none of these patients required surgery. So it does appear to us that if we find the right biomarker, then we have a magic drug on our hands. Adjuvant immunotherapy has been around for some time. Give you a quick snapshot of the rationale for using this. The reason why we use adjuvant immunotherapy is to eliminate undetectable micrometastatic residual tumors and destroy them. Just to exemplify one study, Keynote 564, this is a study of renal cell cancers, high-risk renal cell cancers, post-surgery, post-nephrectomy, randomized to receive placebo versus checkpoint inhibitor pembrolizumab, and this did show significant overall survival benefit. You can see the curves diverging as early as 2 years, and the divergence, the delta, is seen and even more prominent at 48 months. And this is the disease-free survival of use of pembrolizumab in high-risk RCCs in the adjuvant setting. So there are certain advantages and disadvantages of using the immune checkpoint inhibitors in the neoadjuvant versus the adjuvant setting. In the neoadjuvant setting, the advantages which see are that you are treating micrometastasis early, and because the patient is fresh, there is better tolerability and compliance. There is a larger tumor, better immune profiling, and you can assess the sensitivity of these agents once you do the surgery. Once you do the pathological testing on that, you can assess whether your drug has worked or not, and you can look at the pathological responses, which could be a surrogate marker for overall survival, and this shortens the clinical trial timelines. You don't have to wait for the disease progression. You don't have to wait for the patient to die, and you can just in 4 or 6 cycles or a short period of 3 to 4 months, you can judge the efficacy of the treatment. What are the downsides? Of course, every intervention has downsides also. 100% of patients don't respond. Few patients will progress, and potential delay in the definitive treatment may happen. There may be risk of increased tumor complications. When the tumor is increasing in size, there is a chance that some patients from non-metastatic could become theoretically metastatic. If you combine both neoadjuvant as well as adjuvant immunotherapy, or what is now known as perioperative treatment, then you have both advantages. You can maximize tumor shrinkage and also produce better systemic control before surgery. And in the adjuvant setting, you could take care of the micrometastasis, which happens sometimes when you do surgery. A lot of people believe that once you manipulate the tumor, then you are releasing some of these cells into the circulation. If you've heard Rajan Badwe talk about early breast cancer, he is very fond of mentioning this, and the reason why injections of hormones pre-surgery helps is because you put these cells into dormancy. So ladies and gentlemen, there have been a whole bunch of trials in the adjuvant and in the neoadjuvant and in the perioperative settings done for non-small cell lung cancer. This is just a snapshot of those trials. Lots of agents, checkpoint inhibitors have been evaluated. Pembrolizumab, durvalumab, toripalimab, nivolumab, atezolizumab, you name it, everything is being tried in the perioperative setting. Perioperative meaning before surgery and after surgery. And this is the snapshot of when the checkpoint inhibitors are being used. The majority are being used in stage 3 disease. We are seeing a pathological complete response with neoadjuvant chemo immunotherapy in about a quarter of the patients, and we are seeing a trend towards benefit in overall survival. We did see that in the CheckMate 522, the triple negative breast cancer study. So this was one recent, just about a few weeks back, systemic review and meta-analysis published in the JAMA Oncology, 43 trials, 5,000 plus patients, and they felt the results of this meta-analysis, the pooled overall survival, the hazard ratio was 0.65, favored neoadjuvant chemoimmunotherapy over neoadjuvant chemotherapy. So really large number of trials, large number of patients across clinical trials. And this meta-analysis also highlighted that patients who had PD-L1 less than 1%, they also benefited with neoadjuvant chemoimmunotherapy. So I think those of you who are interested in this topic have to read this. So when you select a patient, a multidisciplinary team approach is very important. You have to have a medical oncologist, radiation oncologist, a surgical oncologist, and a pathologist carefully assess the situation. And of course, you have to have the patient participate in the treatment decision-making factor. There are lots of patients in which the checkpoint inhibitors are indicated, but because of economic factors, especially in our country, we are unable to give them the standard of care treatment. So that remains a problem in our country, and that will continue to remain in our country, and that has to be carefully assessed upfront with discussions with all the related experts and the patient and their representatives. So I'd like to, come close to the conclusion of my talk. Immunotherapy is not without toxicities, and right from top to toe, every single organ system in the body can be involved, there can be inflammation of the organ. So you have to be very alert about this. You can have inflammation in the eyes, in the conjunctiva, in the retina, in the pituitary, thyroid, adrenals, liver, pancreas, GIT, kidneys, skin. So every medical oncologist using checkpoint inhibitors has to be aware of this and has to look for these every time the patient comes to you. In addition to the usual workup which we do, significantly enhanced endocrine workup is required when you are contemplating use of checkpoint inhibitors. Significantly enhanced cardiac workup also needs to be done so that you can detect toxicity early and manage it properly. So just a few words about endpoints in early stage trials. We have survival endpoints, all of us know this, DFS, relapse-free survival, progression-free survival, overall survival. We have response endpoints, objective response rates, complete pathological response rates, pathological response rates, time and duration to response. And then we have other endpoints like disease control rates, clinical benefit rates, and all these things are particularly important when you are doing trials in early stage cancer treatment. So this is again a snapshot of the endpoints which we use in so many trials, and I think I wouldn't go into the details of this. And advantages and disadvantages of the various endpoints. And this is my last slide, the key takeaways for you. So the checkpoint inhibitors, immuno-oncology, immunotherapy has ever-expanding options. We are now using it in neoadjuvant setting, adjuvant setting, and in the perioperative setting, both neoadjuvant as well as adjuvant.
Now I think things are getting more complicated, and in the slides to go, we will try to sort of get this. How does this move? This. One second. This one present in stages 3 and 4, and globally also around 20 to 30% present in early stages. But more importantly, what we see is the survivals of lung cancers across stages. In stage 1, it is around 80 to 90%, whereas when you go to stage 2, it dips to around 50 to 60%, and in stage 3, anywhere between 25 to 40%. So there's a marked decline in the survivals of patients of lung cancers as we go across these stages. So much so, even if you treat it with upfront surgery, nearly 2/3 of the patients do experience recurrences after 4.5 years. Even if you treat it with neoadjuvant chemotherapy or chemoradiation therapy, close to 71% of these patients recur in about 2.5 odd years. And the fact is that once you get a recurrence of these cancers, we know that the survivals of these patients really fall down dramatically. So there is a gap in the management. Clearly we need to do better, and that is where the immunotherapy comes in. And these are recommendations from the American Association of Thoracic Surgeons, the 2023 recommendations, and it essentially says that it has to be considered both in the neoadjuvant and the adjuvant therapy with a category 1 recommendation, and I will come to that subsequently. Sir did mention that there are 3 broad strategies in which you treat these cancers with immunotherapy. One is the adjuvant immunotherapy, in which you tend to operate these patients up front. This was something that we used to do earlier as well. We used to operate and we used to give chemotherapy and possibly sometimes targeted therapies, but now immunotherapy has come in the adjuvant space. The neoadjuvant only therapy is also there, and the classic one is the Checkmate 816, wherein you give only neoadjuvant chemotherapy plus immunotherapy and operate these patients. And the more popular thing, that is Hemant sir did allude, is the perioperative approach, in which you use immunotherapy both in the neoadjuvant and the adjuvant space. And this is in a nutshell what we are going to discuss. The upper arrow shows upfront surgery and 2 positive readout trials, the IMpower 010 and the Keynote 091 of Atezo and Pembro for 1 year duration, and Atezo is for PD-L1 more than 1%. The neoadjuvant only approaches is the classical, the Checkmate 816. We have 3 cycles of Nivo plus chemo, followed by surgery versus surgery alone, and there is no adjuvant in this. And you have at least 6 randomized controlled trials that have been published over the last couple of years of various agents, Pembro, Durva, toripalimab, Nivo, and this is the nivolumab that is given in the adjuvants in the perioperative space, that is the Checkmate 77T trial, and the IMpower 030 of Atezo in the perioperative space. So which patients should require adjuvant immunotherapy? And mind you, these are the patients in whom the patients have been operated upfront. They receive chemotherapy. In the IMpower 010, 1,000 odd patients received Atezo, 16 cycles, compared with the best supportive care or placebo. DFS was the primary endpoint, and DFS was met in all the cohorts, especially in all randomized patients stages 2 to 3A, and in the intention to treat population as well. But it was more pronounced, and especially the overall survival was more pronounced in the subgroup of PD-L1 more than 50%, and not significant in the other subgroups. Another trial of the adjuvant immunotherapy is the Keynote 091, the PEARLS trial. Again, in this, you had to have a complete surgical resection with R0 margin. In this, it mandated a PD-L1 testing. All these tumors had to be, of course, EGFR and ALK wild type. PD-L1 testing in a central lab, received adjuvant provision for adjuvant chemotherapy was there up to less than 4 cycles, and then they were subsequently randomized 1:1 to Pembro 200 milligrams Q3 weekly, and subsequently the other arm was the placebo arm, and you had the dual primary endpoints for DOFS in the overall population as well as in the PD-L1 more than 50%. And again, this was a positive readout in the DFS by the subgroup in the overall intention to treat population across the stages 1 to 3B. And surprisingly, this had in the arm which was a TPS between 1 to 49, it showed slightly best response. So there was a slight difference in the way these tumors behaved in the distribution of the adjuvant PD-L1 subgroups. Atezo, of course, has to be given when PD-L1 more than 1%, but Pembro can be given even otherwise as well. When it comes to the role of the neoadjuvant and the perioperative approaches, and we know that neoadjuvant chemotherapy, there is a 5% improvement in overall survival versus not giving any chemotherapy at all. 13% reduction in death and 6% improvement in RFS is there with the neoadjuvant approaches. The classic trial was the Checkmate 816, and this was the first trial that actually got, based on this nivolumab, got the FDA approval in FDA in 2022, and then subsequently you had all the other agents coming. And here you had, and broadly if you see, majority of these trials, both the neoadjuvant as well as the perioperative trials, the key eligibility criteria were more or less similar. The primary endpoints were also more or less similar. So most of these studies had early stages lung cancers. In Checkmate 816, it was 1B to 3A. In many other studies, it could be 2 or 3. And patients should be driver mutations negative, so they should be ALK or EGFR negative. And then the most important criteria is that they have to be upfront resectable. And of course, the stratification was there in this trial. The primary endpoints in most of the trials were pathological complete responses and event-free survivals. In some of them, they were co-primary endpoints, and some of them, they were just importance endpoint. And you have a host of other secondary endpoint, maximum pathological response, OS, and various other endpoints. And all these trials were positive readout trials, both for PCR, MPR, as well as the EFS. So you had almost 24% of PCRs in the Nivo plus chemo vis-a-vis compared to the 2.2% of PCR in the chemo alone arm. And in the event-free survival also, you had a statistical significant hazards of 0.63 with a very, very significant p-value. 63% in the Nivo plus chemo versus 45% in the only chemo. So this was a positive readout both in the PCR as well as the event-free survival. And more importantly, from the surgical perspective, 83% of the patients in the chemo plus the Nivo arm underwent actually the surgery compared to 75%. So you see about 20% of the patients don't undergo surgery, and that's the real world data. It happens even in the era of chemotherapy. It remains unchanged even in the era of chemoimmunotherapy as well. Of course, nothing alarming in terms of the adverse effects. Of course, most of these adverse effects have been unique for immune checkpoint inhibitors across all the agents. So when do we actually consider this neoadjuvant chemoimmunotherapy? Now, if a patient walks into our outpatient clinic with an early stage lung cancer, I think it's the most important thing is these patients have to be discussed in a multidisciplinary tumor pool. The most important thing is to assess resectability. You will have to have a qualified thoracic surgeon or person or a surgeon who has a special interest in thoracic surgery. Must have a pulmonologist, ideally, because now EBUS US approaches are becoming standard of care in terms of upfront mediastinal staging for these patients. So upfront good mediastinal staging is important. Of course, a medical oncologist is important because you must understand the patients who, whether they are actually fit to undergo this regimen, either the neoadjuvant or the perioperative approaches. You must have the EGFR and the ALK mutations available. PD-L1, it doesn't really matter much because irrespective of the PD-L1, most of these patients are eligible to be in one of these trials. So definitely you should have the EGFR and ALK results available with you, because if they are wild type, then they don't come across for some of these trials. But nowadays, more and more oncologists seems to prefer the broader or comprehensive genomic profile of even early stage lung cancer. So NGS results should be available. And more importantly, as Hemant sir said, that patient should also be on board, because the treatment duration gets prolonged. There are issues with toxicity, so quality of life issues are also important. So the landscape of early stage lung cancer thus is changing, and it has to be best decided in a multidisciplinary tumor board. And again, we have a host of trials, at least 6 randomized controlled trials, multiple meta-analysis, and Sir did allude to a couple of meta-analysis by Jonathan Spicer et al. This was a trial that was published in the NEJM, the AGN of durvalumab last year. Again, this was the neoadjuvant approach, 802 patients, again similar inclusion criteria, durva versus placebo. Again, you had 4 cycles in this case. Again, how many cycles of neoadjuvant to give, whether 3 or 4, some say 3 is better. In the durva, they had about 4 cycles. Pembrolizumab in the keynote, which I'm coming to, again 4 cycles. So at least 3 cycles, and that seems to be the flavor of the day. But in terms of keynote 671, which I'm going to say 4 cycles seem to give an overall survival benefit. So we don't really know whether it's 3 or 4, but at least 3 for sure. And then subsequently you go the patients undergo surgery in both the arms, and durvalumab in one arm versus placebo in another arm. 30% of them were stage 2. It's very important because Sir did allude to the higher the stage, the responses seems to be slightly better. So again, if you see, there seems to be a slightly divided opinion of the house whether you should push for the chemoimmuno approaches in the stage 2 lung cancer patients, and that seems to be a divided house even in the ISLC consensus statement, where almost 50% said they should go. Of course, at that time, the Jonathan Spicer's meta-analysis published in JAMA, which Sir said was not available for them, that even in stage 2, the meta-analysis showed a hazards of 0.73. So the benefit is there in stage 2 also, but still there are some skeptics who say that you shouldn't really push to. But there are some subgroup of patients in the AGN as well as in many other trials that stage 3 patients, although minority, a vast majority of the patients were actually stage 3 patients across all the immune oncology trials. And again, what we find is there was a positive readout both for the event-free survival as well as the PCRs and the MPRs. 17% PCRs in this study, 33% maximum pathological response rates. Again, benefit across PD-L1 groups. Again, to highlight the same thing here, 17% of PCRs versus the 33% of maximum pathological response. Again, a positive readout trial, the AGN for durvalumab. This was the NeoTORCH study, again involving another immune checkpoint, the toripalimab. Again, you give it in the neoadjuvant. This had an adjuvant phase. Again, as I said, the flavor was to give 3 cycles. So in this case, possibly they gave 3 cycles of chemoimmuno. After surgery, they gave the 1 extra cycle, and then subsequently the maintenance of the immune regimen was there. Again, you had 78% were squamous cell carcinoma patients. Impressive 25% PCRs in this group, and a positive readout for the event-free survival hazards of 0.40. And again, benefit across various key subgroups, including the PD-L1 expression. And the keynote 671, and I think this was the only trial, in fact, Sir also alluded to, that there is an overall survival benefit. A lot of the trials actually had their endpoints as PCRs and the EFS, but this was one of the trials in which the OS was also included. And again, this was a trial in which 4 cycles of chemoimmuno was given. Again, as I said, the key eligibility criteria, the stratification, and all are by and large similar across all the perioperative trial patients. Pembrolizumab along with chemo versus chemo, then surgery, followed by adjuvant pembrolizumab for about 13 cycles, dual primary endpoints of EFS and overall survival, and you had a positive readout both in the EFS with a significant hazards of 0.58. Again, the benefit was across all key subgroups. And in the post hoc analysis, irrespective of the end status, irrespective of the clinical stage, the benefit was there. Again, when it comes to surgery, if you didn't perform surgery for some reason, I think the bar was straddling across unity. And again, if you did not have an R0 resection, that is, if you had an R1 or the R2 resection, you had the plot crossing across unity. So means to say that it would be preferable that these patients undergo surgery and these patients undergo an R0 resection. Again, this is the data to show the overall survival benefit of these patients at 48 months, 67% versus 51% with an impressive hazards of 0.72. This is the Checkmate 77T. This was using nivolumab, but nivolumab in the perioperative space. You had the Checkmate 816, which was nivolumab only in the neoadjuvant space, and you had this Checkmate 77T, in which you had to use it in the perioperative space as well. Again, key eligibility criteria pretty much similar across all these trials. 461 patients randomized 1:1. Again, the primary endpoint was the event-free survivals for some of these patients, and this again was a positive readout for this. Again, impressive PCRs with nivolumab also. 25% of pathological complete responses as 35% of maximum pathological responses, and the EFS was also positive with a hazard ratio of 0.56. Again, the benefit seems to be there across all the subgroup of these patients. This was another randomized trial, controlled trial of another agent called tislelizumab. Again, this was a similar key eligibility criteria. You used randomized 1:1 of this agent, again 3 to 4 cycles, surgery, similar design. And what is impressive about this was the PCR rates were very impressive. 40% of PCRs, which generally in the immune checkpoint inhibitors, you get around 17 to around 20%, but in this study, there was a 40% pathological complete response rate. Seems to be pretty much impressive, and 56% of the maximum pathological response, again, which is pretty much impressive. Of course, I don't think that we have much experience of using some of these agents, but maybe as in one, these agents are available and the data mature, you can consider some of these agents. Again, considering the surgical perspective, close to about 80% of patients underwent surgery, and I feel this is a good number. Some people use this as a critique. They say, like, you use the neoadjuvant chemoimmuno approach. Some of these patients don't even come for surgery, whereas you assume that in real world everybody comes to surgery if you do upfront surgery, but that may not be the case. Even in the neoadjuvant chemo approaches also, you had an equal or possibly more number of patients not coming for surgery as well. So I feel that this amount of patients coming up for surgery should be a reasonable, decent figure. Immune toxicities are one of the predominant reasons why these patients don't come up for surgeries. Sir did mention about these slides. You have immune toxicities pretty much unique across all the organ systems in the body. And again, the other million-dollar question is, having achieved a PCR, whether you want to give adjuvant immunotherapy, that is because it adds to the cost, it adds to the definitely financial toxicity, quality of life, whether you're really doing any benefit for some of these patients who have already achieved a PCR by adding immune checkpoint inhibitors in the adjuvant space. Again, there is a data to suggest that the benefit is there, irrespective of you achieving a PCR or not achieving a PCR. But I guess there is a treatment gap, and we need to really understand these things. Maybe some important biomarkers, some important bispecific antibodies, targeted therapies. So I think there is some important research question that really needs to be addressed in this space. But so much to say, for now, we go as per the trial design. We give it for all patients who achieve PCR and who don't achieve PCR. But again, this is a question that we need to analyze and understand really better across the trials. Again, an important consideration from the surgical perspective, and I said, there are 3 important caveats in all these trials. The patients should be resectable, and what actually constitutes resectability. And this was the EORTC resectable criteria. This was also presented in the World Lung Cancer Conference in 2023. And by and large, I think this is something that most of us used to follow earlier as well. But I think since it's given in a blueprint, it seems to be pretty much useful. So again, the reds are the ones that are unresectable. So with regards to the N2 disease. That's the major contentious issues, because you have 5 different variants of N2 that can happen. We know that if it is an N2 invasive, again, most of us, or none of the surgeons, I believe, would touch this patient. If it's an N2 single non-bulky, and again the definition of bulky seems to be whether it's 2.53 or something like that, there is a contentious issue. But by and large, if it's a single non-bulky, you would sort of consider this patient as resectable. N2 non-bulky with multiple. The sense these are some of the gray areas on a case-to-case basis. Some of these patients would come the neoadjuvant chemoimmuno way. Some of them may not come. So these and the N2 bulky ones, like for example, if they are more than 3 centimeters with extranodal or something like that, whether they come to not, again there could be slight difference. So it is very important. And this is all discussed in a multidisciplinary. By and large, the extremes, the N2 single non-bulky or the N2 invasive are the ones which we are pretty much clear in what approach we need to do. But in the other two, the N2 bulky and the N2 bulky non-bulky multi-station are the ones that can be discussed in a multidisciplinary tool. And this is an important table that I guess should be stuck possibly in every multidisciplinary tumor board to aid everybody in the multidisciplinary tumor board have some opinions. The other issue that was said is the performance of surgery. We did discuss that again, more than 80 plus patients did come across to the board for surgery, but the initial results seem to suggest that the conversion rates from minimally invasive to open approaches seems to be pretty high. Definitely, of course, my experience of operating on patients with chemoimmuno is limited, but in whatever patients we have operated, there is slight amount of technical difficulty, especially if the tumors were centrally placed, especially if there were nodes or N2 disease. But by and large, if it's peripherally placed and it's N0, it seems to be reasonably okay to do. So there was initial scare that some of these patients would have a more amount of injuries, vascular complications because of the fibrosis. And it's true, because some of these immune checkpoint inhibitors induce a lot of fibrosis, especially in the mediastinum and in the nodes that are actually sort of become N1 to N0 or N2 to N0. No, all those nodes actually react in a slightly different way, making surgery slightly difficult for us. But by and large, over the years, we have seen some data, including our own experience and some real world data that has been published, to say that minimally invasive approaches, again, as I said, like if the tumors are slightly far away from the hilum, if the nodes are slightly smaller, sometimes if the nodes are N1 or N2, or if the nodes are N1 and have actually responded very well, now those are the patients that are slightly tricky. Of course, as qualified thoracic surgeons, we tend to understand these nuances and try to sort of convert when we feel it's not safe for us to proceed with these surgeries. But by and large, the studies have said that in terms of conversions, blood loss, operative time, intraoperative complications, by and large, there is not much of a difference. Some surgeons say that if a surgery exceeds more than 2.5 hours, they say that there is a problem. The sense like there is a finite amount of time, especially in thoracic surgeries. You have to finish it within a finite amount of time. So that's the reason where that's also an arithmetic we also keep in mind. They also tend to classify surgeries as challenging cases. They have a gradation of 1 to 4, and then take the decisions for conversion based on this. But so much to say that thoracic surgeons should get used to operating in patients with post-chemoimmuno, because that's going to stay for now. Again, this was the positive readout of the Keynote 671 study. Again, about 71 patients in the pembrolizumab arm and 82 patients in the placebo arm actually did not undergo the in-study treatment. It seems a pretty large number, but I guess in real world, that's what tends to really happen. And most of the times, it's because either due to an adverse event, because of this, as I said, the adverse events from the immunos, they are slightly unique, but there is something that needs to be factored in. Sometimes it could be an administrative delay. Now, we don't really know which is the best time to operate these patients. A lot of studies, at least in the NEVO, they said less than 6 weeks. The ideal timing, they say, is around 4 to 6 weeks. Very recent, some paper says less than 4 weeks, better the responses. So we don't really know. There's not much of robust data to suggest when is the ideal time to operate these patients. But by and large, we stick to the 4 to 6 week window. Earlier, slightly the better for some of these patients. Again, the host of reasons why the patients did not undergo. Sometimes you may have, very rarely, you may have some clinical progression, and this is pretty much rare. Of course, in real world, you could have patients refusal, physicians deciding not to operate for various reasons, progressive disease, etc., and withdrawal of consent. So by and large, lobectomy seems to be a safe and standard approach, and the vast majority of the surgeries did achieve an R0 resection in this randomized control trial, which is heartening to note for many of this. Again, this was the slide which Hemant sir had shown. Significant amount of downstaging does happen, about 30% this way or that way. It does happen more so in the Pembro plus chemo arm as compared to the only chemo arm. So again, this is my final slide. I've sort of, covered a lot of things. Although I'm a surgeon, I think I was made to talk a lot because I think that's the flavor of the day. The immunotherapy is actually the flavor of the day. It's important for us to also understand this language, and that's the importance of having a multidisciplinary tumor board, I must say. So, as I reiterate, the final take home is even the early stage lung cancers, it's becoming much more and more complex nowadays. We have to have, they say, an NGS report available to you, of course, or at least an EGFR ALK report. Clearly, these patients have to be wild type, they have to be resectable. If they fit into these two criteria, then even if it's stage 2, definitely if it's stage 3, you have to go the chemo immuno way. That's what, because the results are very clear. And I think the results are also compelling for stage 2. Also, a serious consideration to give a chemoimmunotherapy even in your stage 2 resectable EGFR ALK wild type lung cancers has to be made under the purview of a tumor board. And I think we have to sort of, and as thoracic surgeons, we must embrace the fact that, surgeries are going to be little bit of technical challenging will be there, but I think it's worthwhile taking that extra effort, because at the end of the day, if you have more better responses, if the patients are living longer, living better, I think that's the way to go. So with that, I would sort of end my talk. Sorry for the technical glitch, but happy to take any questions. Thank you. Fine.
So, Arvind sir, it was a pleasure listening about immunotherapy from you. So, a welcome change. Hemant sir, we have always been discussing it in our meetings, but this was really nice. So, any questions? You have both the experts. Anyone, any questions? Sir, please.
Hello. So in real-time world, the non-compliance is the biggest problem of immunotherapy, I feel, sir. What do you think?
Non-compliances.
Yeah, I think before you start expensive, complex treatment, you have to make a very careful assessment. The most important thing in our country is the economic assessment. And if 10 doses of medicine is required and the patient takes 2 doses of the medicine, then it is the fault of the assessing evaluation. So I completely agree with you that all efforts expended in explaining to the patient and the family what is required in details is well worth its time.
What's the role of, hyperthermia intraperitoneal chemotherapy?
So, wishful.
I don't have any personal opinion or any personal experience on this, sir. But I guess, as a standalone procedures, these procedures are sort of, very helpful. No. Currently, as a procedure per se, these procedures. But whether you mean to say you use immuno and then use some of these agents?
Or you want to use you want to use immuno as an agent in the HIPEC surgery, or? So, I think the basic problem will be immunotherapy takes time to act. It's not it doesn't kill the rapidly growing cells as a chemotherapeutic agent. So either a neoadjuvant immunotherapy might be something which can be discussed in trials, but I don't think giving immunotherapy peritoneally or in any cavity will act because it doesn't have a mechanism of action of that sort.
Before it is starting epic or
Neoadjuvant.
No, I agree, sir. So at least in lung, I must say, like, that most of the times, one of the criteria is